Welcome everybody. My name is Dr. Mark Lobbes. I'm a breast imaging radiologist from the Zuiderland Medical Center. And I would like to give a short presentation on contrast-enhanced mammography and a short introduction on how to read these kind of images based on several case examples that I would like to show you. I've been practicing contrast-enhanced mammography since November 2012 and have an extensive experience of over 2,000 images that I viewed or reviewed, and I also am the author of several scientific publications also on the topic of contrast-enhanced mammography, including several book chapters in textbooks. First of all, a small disclosure and a small summary of what contrast-enhanced mammography looks like. So, as explained in one of the previous presentations, contrast-enhanced mammography is a sort of a dual energy mammography technique in which you first inject a dose of iodinated contrast agent into the circulation of a patient. You wait for 2 minutes and then you acquire a dual energy mammogram of both breasts in both views in a time period of approximately 8 to 10 minutes. And the final result is that you get, first of all, you get a low energy image, which is exactly the same as a normal mammogram in terms of image quality and positioning and everything else you can think of. And rapidly after that, high energy is being acquired. As you can see in this middle image, the high energy image is sort of targeted to spot areas of contrast uptake and is not suitable for diagnostic purposes. It is mainly used together with the low energy images to reconstruct what they call a recombined or an iodine image, in which you can appreciate areas of contrast uptake. And as you can see, the diagnostic accuracy of a normal mammogram is therefore decreased when you compare it to the left image of the normal mammogram. On the recombined image, you can much more easily appreciate that it's a multifocal cancer, and you have much more feeling as a radiologist on the true extent of the breast cancer. So I want to touch on several things regarding contrast-enhanced mammography based on a handful of cases that I want to show you. So in this case, which are all from clinical practice, we had a 54-year-old female without any relevant prior history. She detected a palpable mass in the breast during a shower, something which occurs very frequently. She's very anxious for breast cancer because her mother died of breast cancer at a rather high age. So this is the low energy image of both breasts in a mediolateral oblique view. And this is the subsequent image of the craniocaudal projection, also of both breasts, regarding the low energy image. And as you are familiar with contrast-enhanced mammography, you have the recombined images of both breasts in mediolateral oblique view. And you also have the craniocaudal view of both breasts. Now, as you can appreciate, I think it's very easy to see, especially on the recombined images, that there was a unifocal abnormality in the left breast, for which we did a targeted ultrasound, and this is the lesion that you then can appreciate in that area, which I think is very suspicious for underlying breast cancer, and it was subsequently biopsied. So to summarize this specific introduction example, there was if you looked carefully, there was an ill-defined mass in the upper outer quadrant of the left breast, had irregular contours and spiculations, and there was sort of moderate enhancement at the site of the mass. It's not very high as what you would normally expect of an invasive breast cancer, but still it was very clearly visible because there weren't any relevant artifacts to be seen in that area. Well, the final pathology showed that there was a 15 millimeters invasive breast cancer of no specific type. So it's a rather straightforward case to begin with. Now, if you look at the mediolateral oblique recombined images in which you can clearly appreciate the tumor in the left breast, You can also see several artifacts which are very common for contrast-enhanced mammography. And although they are generally appearing in slightly older generations of contrast-enhanced mammography machines, they are very easy to detect, and it is to be expected that they will disappear more and more when the technique improves and when new software algorithms come out. So there's a very well-known artifact which is called the breast-in-breast artifact, and if you look carefully you see this as a very lucent peripheral zone in both breasts, which is slightly less in intensity than the rest of the breast, and it follows the contours of the breast a little bit. In my personal experience, when you learn this artifact and you know how it looks like, it's very it doesn't really bother you that much in terms of diagnostic quality. Something similar is for the skin line enhancement artifact, which you see in the caudal parts of both breasts. You see a slight suggestion of skin thickening and skin enhancement, but if you sort of are in doubt about whether this is a true abnormality or an artifact, you can go back to the low energy images, and then you can appreciate that the skin looks absolutely normal over there, and then you can assume that this is a skin line artifact associated with contrast enhanced mammography. Another important artifact to mention, which you can appreciate predominantly in the right breast in the caudal parts in the prepectoral zone, is the ripple artifact. You see these small black wavy lines occurring in the recombined image, and this is just a slight movement of the patient in between the image acquisitions of the low energy and the high energy image. So it's roughly a sort of a slight mismatch between those two images, which is most pronounced in the recombined image, of course. But again, these are very common artifacts. Sometimes the ripple artifact can be a little bit diagnostically challenging because if they're too extensive, you cannot appreciate areas of contrast uptake anymore. But in my experience, when you look at newer generations of software algorithms, these are improved extensively, and they will be becoming less and less of a problem in future generations of machines. So the second case is a 50-year-old female which was recalled from breast cancer screening. She attended for the first time and she was immediately recalled from breast cancer screening. Like it's normally the case in referrals from breast cancer, she had no complaints, and in this case she also didn't have any prior family history or any relevant risk factors to mention. Again, as in the previous case, I will show you first the mediolateral oblique views of both breasts in low energy. The same for the craniocaudal views of both breasts. And again, I forgot to mention, you can also ask technicians to do specific special views if you're interested in that. You can have detailed views, rolled views, extended lateral views, anything that you're familiar with from normal practice. You can do as easily on contrast enhanced mammography as you can do with other mammography techniques, and therefore it's also preferable to, as a doctor, if it's possible, to be in the room with the technicians when you acquire the images, sort of to direct the technicians of what kind of images that you want to view. So next there's the recombined images of both breasts in two views. And again, these are the craniocaudal views of both breasts. And if you look carefully in the medial part of the right breast, you see a small, quite well-defined oval mass enhancing on both images, but it's best appreciated on the craniocaudal views. And we targeted it with ultrasound, we found a lesion, we biopsied it at the correct position, and it turned out to be a fibroadenoma. So not all enhancing structures that you observe on a recombined image are suggestive of invasive breast cancer or DCIS. Some benign entities like fibroadenomas, hamartomas, papillomas are also very known to cause some kind of enhancement and can be a cause of false positive findings in contrast enhanced mammography. So to discuss this case, there was an ill-defined mass, partly obscured by the mass was partly obscured in the lower inner quadrant. No other findings, and we already seen that it showed slight enhancement on the recombined images, and it turned out to be a fibroadenoma, which was subsequently confirmed 2 years after this analysis. She wasn't recalled for another or an evolving mass in a subsequent screening round, so this was a false positive finding. We found something which was benign, but at least we didn't overlook any cancers elsewhere in the breast. Now, most important to show you also in this case is that there were several artifacts in the craniocaudal views of both breasts, and I didn't know if you detected them when you looked at the images, but it's just to emphasize that it's very important to know the artifacts which are associated with contrast-enhanced mammography, and therefore also know the artifacts which are not associated with contrast-enhanced mammography. And in this case, you saw small, sort of rectangular, well-defined lucencies in the recombined images, which were due to improper calibration, due to a service round or a maintenance round of our equipment at that time, and which was associated with sort of the phantom still shining through on the recombined images. So in this case, there was a proper calibration of the low energy images, but an improper calibration of the images that are associated with the recombined images, and that turned into these artifacts. So again, the take-home message for this case is that learn to know the artifacts that are common in contrast-enhanced mammography, and if you know them and you are experienced with them, they shouldn't be any cause for diagnostic dilemmas, but also know the artifacts which are not associated with contrast-enhanced mammography, and which should be a cause to consult your technicians to see how to solve this problem. Now, next case, case number 3, again is a 50-year-old female. Again, first round of breast cancer screening, no relevant complaints, no relevant risk factors or family history. And she presented to us with this mammogram. This is the low energy image. Again, both breasts in 2 views. I think the abnormality is very clearly visible, so this is not a challenging case, but it's a very representative case of something which I will mention later. And again, lesion is also seen in the right breast, I think, very easy on the craniocaudal views of the low energy images. But on the recombined images, you see this appearance on the mediolateral oblique view, and you see this appearance on the craniocaudal views. Now, when we, for this case, did a targeted ultrasound, we found a very well-defined anachogenic focus, which resembles the typical appearance of a simple cyst on ultrasound. We also performed an aspiration to confirm it specifically for this case. But to be honest, this was already very typical of a simple cyst. So you had a well-defined hyperdense mass at the 6 o'clock position, and on the recombined images you saw that it was not enhancing at all. In fact, there was a slight black void occurring over there, which is very common because a simple cyst is just a small ball or a small mass filled with water, doesn't contain any blood vessels, so also no contrast will be present in that area. So this results in a sort of a black void on the recombined images, which some people call a well-defined negative enhancement, or some people call an eclipse sign, because it resembles the appearance of a solar eclipse that we know from the skies. But this is the very typical appearance of a simple cyst, and if you see these kinds of lesions, there's no need to do a targeted ultrasound anymore to confirm that this is a cyst. So again, in this case we did do an aspiration, sort of in the light of teaching. We did do an ultrasound guided aspiration, and we did check it on a subsequent mammography, and you see that the lesion has disappeared, confirming that it was a cyst. Now, case 4 is a 52-year-old female. She was recalled in her second round of breast cancer screening. Also, again, no complaints, which is very common in these kinds of recalls. And this was the appearance that we had from the mammogram. This is the low energy image of both breasts in the mediolateral oblique view. And again, this is the craniocaudal views of both breasts in low energy setting. These are the supplemental recombined images in mediolateral oblique view. And to complete the contrast enhanced mammography examinations, these are the craniocaudal views, as you can see here. Now, there were two things that were visible. As you looked closely, you saw one lesion in the left breast and one lesion on the right breast. And these are the subsequent ultrasound images that were associated with that. Now, if you had a final look, we saw on the low energy images on both sides, we saw a well-defined masses. On the right, this mass showed moderate enhancement, and on the left it showed no enhancement, similar like in the case that we saw in the previous example, which resembles a cyst. So there was actually no need to perform an extra ultrasound, but in this case we performed it for teaching purposes. And on the right it turned out to be an epidermoid cyst. So again, some benign things can enhance, but at least the morphology was very benign looking. Case number 5. Case number 5 is a 47-year-old female. She was recalled from a private practice somewhere else because they already detected on ultrasound and on physical examination a suspicious breast lesion. And in our institute, it's very common if somebody else, for whatever reason or whatever way, detected a suspicious breast abnormality, we immediately go to contrast-enhanced mammography. We do this because we think that it helps us in the preoperative staging. We can easily assess the tumor extent, whether there's a multifocality or multicentric lesions, or if there's any contralateral breast cancer. And in one-stop shop approach, we can do the necessary biopsies, and together with the imaging, sort of the preoperative staging, including the axillary ultrasound of both sides, and together with the final histopathology results, they can go to their first visit at the surgeon with a complete package of preoperative staging, which sort of speeds up the diagnostic process a little bit. Now, this is the mammogram, the low energy images of both breast and mediolateral oblique view. And the accompanying images in the craniocaudal view. Next, I will show you the recombined images of both breasts. You can see, if you look closely, some skin line artifacts and the very common breast-in-breast artifact. And those artifacts can also be appreciated on the craniocaudal views again. But there's also a very apparent breast abnormality in the right breast, which looked something like this on ultrasound. And the suspicious appearance on ultrasound made us perform a biopsy of this structure. And again, on the low energy, you already saw an ill-defined, very irregular mass in the right breast, in the upper outer quadrant. Sometimes a little bit difficult to delineate to what the true extent is, especially if you have spiculated margins or architectural distortions surrounding it. And it showed very strong enhancement on the recombined images. So when it's a very avid enhancement on the recombined images, is becoming more and more suspicious for malignity. There are some studies that looked at the amount of enhancement in terms of what the gray level value was for different lesions, and you see that they are slightly higher for breast cancers when you compare it to benign entities, but it's very difficult to visualize that, to eyeball that. So perhaps there's a window of opportunity to do things like machine learning or artificial intelligence on those kinds of structures to help us as a radiologist to increase the interpretation detail of contrast-enhanced mammography. But that's something for the future, I think. There were no other lesions, and on final histopathology there was a 28 millimeter invasive breast cancer to be found. Now again, you can quite clearly see the mass over here. There are no significant disturbing artifacts in this image, so it's very accurate to delineate the breast mass, and you can very accurately assess tumor size. And in fact, when you look at different publications regarding tumor size assessment, you can see that there's no really relevant difference between tumor size assessment between contrast-enhanced mammography and breast MRI. So that made us feel confident that when we have a very good contrast-enhanced mammography exam in terms of image quality, and we're very confident that we can accurately delineate the tumor contours, we don't see any necessity anymore to perform a breast MRI. Now, case 6 is a 60-year-old female, also recalled from screening, because that's the predominant population that we have in our institute. Recalls from screening, evaluated with contrast-enhanced mammography. Again, no complaints, and she had a slight family prevalence of breast cancer, her mother dying of breast cancer at the age of 52, so she was also a little bit anxious. Again, this is the low energy image of both breasts, mediolateral oblique view, and this is the subsequent craniocaudal view of both breasts. And because this case is slightly challenging, I'll give you some extra time to look at it, but I also have a detailed view which sort of gives away the area of interest, but it's very difficult otherwise to emphasize the area of interest. In this area you see some small calcifications. They might have some linear orientation, but it's not very convincing in my opinion. Difficult to interpret some architectural distortion over there. And this is how the subsequent recombined image looks on the mediolateral oblique view of both breasts. And in turn, this is the craniocaudal view of both breasts, which in general, in my opinion, is sort of the preferred image projection to look at on contrast-enhanced mammography. And you can clearly see there is some difference in enhancement. You see an area of non-mass enhancement occurring in the medial part of the breast, where you also saw these breast abnormalities and these slight calcifications. And you see, well, a small, very small enhancing oval nodule on the retroareal region on the left breast. We thought that both areas were of interest, so we did a targeted ultrasound of both lesions, and this is what we found in the medial part of the right breast. We saw some irregularities, vertically orientated, some dispersed small lesions, but no really big mass. So that sort of gave us confidence that it was probably a multifocal breast cancer, presumably in an area of a more extensive DCIS component. And on the left side, we didn't find any abnormalities. So in the end, on the right breast, on the low energy, we have some linear orientated calcifications, very subtle, not very convincing, but also some small irregular masses that were occurring there in an area that was a little bit distorted. You didn't have a very good feeling as a radiologist about it, but there was no really big mass or extensive areas of calcifications. It was a little bit patchy enhancement, but the predominant finding is that it was asymmetrical according to the left breast. And again, as a chance finding, we had a small enhancing mass at the 12 o'clock position in the left breast, which we couldn't retrieve on targeted ultrasound. Now, as we already suggested, we had a multifocal small invasive breast cancer in the right breast, but it was located in a large area of DCIS up to 7 centimeters. So, and that's sort of what you got the impression of on the contrast-enhanced mammography. On the left side, again, we didn't find anything on the targeted ultrasound. We went to MR-guided biopsy, and this was just a focal spot of adenosis as an explanation for the slight enhancement observed over there. Now, next case, case 7, is a 49-year-old female recalled from screening. A little bit young to be recalled from screening in the Netherlands, as it's usually up to 50 years until 75 years. But we invite these women according to postcode and living address in the year in which they will turn 50. So it's not very uncommon to have 1 or 2 49-year-old females occurring in your population of recalls. Now again, this is the low energy image of both breasts in 2 views, in the mediolateral oblique view, and subsequently also in the craniocaudal view. And I will show you now the recombined images. Now here is when it's becoming a little bit more difficult, because in both breasts, in the mediolateral oblique, we have extensive ripple artifacts. So it's becoming more and more challenging to really confidently appreciate these kind of images. So when the ripple artifacts are these extensive, it's becoming more challenging. But luckily they weren't so present on the craniocaudal views, in which the compression is more homogeneously dispersed probably. And what you observe there in the upper outer part of the left breast for the lesion which you was recalled, you again see a sort of negative enhancements. You see a black void occurring, slightly less defined as what you would like, because there's also some overlapping glandular tissue which shows some background enhancement. And when you did a targeted ultrasound, you see a well-defined mass, anachogenic. And again, this is a case of a negative enhancement at the location of the mass that she was recalled for, a so-called eclipse sign or negative enhancement, as whatever you like to call it, which was based on a simple cyst. She didn't prefer to have it aspirated, and after subsequent screening rounds, she wasn't recalled for that lesion anymore. Now, case 8 was slightly different, was no recall from breast cancer screening, but was a woman priorly treated for breast conservative therapy, and she didn't have her annual follow-up examination. She noticed something changing in her scar. She was anxious, and she went back to the medical oncologist prior to her regular appointment each year. The oncologist was also not very confident that the surgical area was feeling normal. And in these cases, when somebody comes back early in their follow-up, notices changes which are a little bit suspicious, not very confident to rule out breast cancer, we immediately perform contrast-enhanced mammography. And in this case, you see a treated breast on the left side on the low energy images of both breasts, mediolateral oblique view. The subsequent craniocaudal images of both breasts. And here you can also appreciate the recombined images. Again, you see the breast and breast artifact, mainly in the left side, some skin line enhancement, and in the caudal part you see some slight ripple artifacts, but none of these artifacts are, in my opinion, diagnostically a dilemma. And again, the craniocaudal views of both breasts. Now, as you can plainly see from already the low energy images, she had treatment of her left breast, breast conservative treatment. She had some loss of volume of her left breast and some diffuse skin thickening due to the radiotherapy effects. But within the scar tissue, you see also some faint enhancement occurring, which, similar to breast MRI, at least after 1.5 years, you shouldn't expect at a surgical site in a patient who was treated with breast cancer. So any kind of enhancement after that period, similar to breast MRI, should be considered suspicious. So we performed a breast biopsy in that area, and we eventually detected a recurrent invasive breast cancer at the site that she was previously operated. And following that, she got a mastectomy of the left breast. Now, case 9 is a 60-year-old female, again recalled from breast cancer screening without any complaints or relevant history. This is a slightly challenging case. These are the low energy images of both breasts, mediolateral oblique view, and the subsequent craniocaudal views of both breasts. And again, for teaching purposes and to help you a little bit, there's a detailed view of this part, which was the area of interest. And again, if you look closely, and especially if you have dedicated monitors, you see some very small subtle calcifications occurring over there, which was new for her. You see some small architectural distortions over there, so you as a radiologist, you feel that there's something changing over there. And when you look at the contrast images on the recombined views, You see an area of very finger-like non-mass enhancement over there, and those fingers sort of end up with small nodules, which can also be appreciated on the craniocaudal view. And it's very important to notice again the asymmetry. Sometimes you can have some background parenchymal enhancement like you have in breast MRI, but then usually you see this patchy enhancement on both breasts in sort of similar fashion. But if you have a very apparent asymmetry, you should be careful and at least look at it more carefully on the low energy images to detect whether you have any calcifications over there, or perhaps do a targeted ultrasound of that area. And for the future, we also will have the ability to do contrast-enhanced guided biopsy. So although the chances that you don't find any abnormality while you have an enhancing lesion are very rare, I think, at least in the future, there will be the ability to, similar to breast MRI guided biopsy, to do contrast-enhanced guided biopsies with vacuum systems to also solve these kinds of problems. Now in this case, we saw small nodules over there. We biopsied it. We found an invasive breast cancer, and the patient was subsequently treated like that. And in the end, we found a very small invasive breast cancer, 6 millimeter, but the area of DCIS was much more extensive. And again, you can appreciate that very well in the recombined images. You see these small nodules, so it's probably the invasive component, which is probably multifocal. But you can also see this non-mass enhancement without any really mass shaping in that area, which is suggestive of DCIS. And sometimes in tumor board meetings, we have this discussion, well, okay, doctor, is this a T2 staged tumor, or is this a T1 stage tumor? And with the help of these kinds of appearances on contrast-enhanced mammography, I think in this case you would recommend that your preference is to a multifocal T1 invasive breast cancer in a large area of DCIS, and not stage 2 invasive breast cancer, which sometimes can have consequences for surgery, for neoadjuvant or adjuvant chemotherapy, or even oncoplastic surgery. So these kinds of examples can help you sort of direct your colleagues into the appropriate treatment strategy. Now, case 10, 60-year-old female. Again, recall from breast cancer screening. She had a frozen shoulder on the right side, which you can see in the mammographic positioning, which is slightly suboptimal, but probably cannot be performed better due to her shoulder complaints. Again, this is the low energy image of both breasts, mediolateral oblique view, the accompanying craniocaudal view on the left side and on the right side, and the subsequent recombined images in mediolateral oblique view, and also the craniocaudal view. Based on these findings, we performed an additional targeted ultrasound and found a suspicious mass. We biopsied this mass, and it turned out to be an invasive carcinoma of no specific type of 2.5 centimeters, also lymph node positive. And I think the most important thing that I want to emphasize in this case is that mainly on the low energy, there was a highly speculated mass with a lot of architectural distortion surrounding it. And me as a radiologist, it's also very difficult then to assess the tumor size. Do I take these speculations into account, or are they desmoplastic reaction based on the tumor which is located over there? And as you can see in this case, the enhancement of the tumor gives you much more confidence in assessing the tumor size accurately for treatment purposes. Now, to close off, I want to put your attention on two publications on which myself I've cooperated in. I was lucky to edit one of those books together with Maxine Jochelson from the New York Memorial Sloan Kettering Cancer Center. I have no financial disclosures to report. But I think both books are very interesting to read, especially if you want to get familiar with contrast-enhanced mammography. All the most important scientific publications regarding this topic up till now are sort of summarized in that. There are extensive reference lists which you can look up to if you want to go into more detail, but they cover a very broad spectrum of contrast-enhanced mammography indications, like preoperative staging, like response monitoring to neoadjuvant chemotherapy, high-risk screening, you name it, all different kinds of indications that we are usually used to doing breast MRI for are also covered in these books, and it also helps you to get an idea about the physics of contrast-enhanced mammography and how you start to set up a contrast-enhanced mammography system and protocol within your own hospital. So I think both books are equally interesting to read, and I would certainly recommend everybody who is trying to get familiar with contrast-enhanced mammography. With that, I would like to end this presentation, and thank you very much for your attention.